If you're over 60, you've probably been told that the key to staying healthy is getting regular checkups, screenings, and tests. More tests mean catching problems early, right? Well, I'm a physician with over 20 years of experience, and I'm about to tell you something that might shock you. Some of the health screenings you're getting, some of the tests your doctor is ordering, might actually be doing more harm than good. And the medical community knows this, but many doctors keep ordering these tests anyway. Now, before you think I'm telling you to avoid your doctor or stop taking care of your health, let me be very clear. I'm not some anti-medicine conspiracy theorist. I'm a practicing physician who believes in evidence-based medicine. And the evidence shows that certain screenings, when done on older adults, lead to unnecessary procedures, dangerous treatments, significant anxiety, and sometimes even death, without actually extending your life or improving your quality of life. By the end of this video, you're going to know exactly which 7 screenings and tests you should think twice about after age 60, why they can be harmful, what the actual medical evidence says, and most importantly, how to have an informed conversation with your doctor about whether these tests are right for you specifically. Because here's the thing, medicine is not one size fits all, especially when you're over 60. Let me start by telling you a story about a patient I'll call Margaret. She was 68 years old, active, healthy, no major medical problems. She went in for her annual checkup, and her doctor ordered a full-body CT scan as a preventative screening. The scan found a small nodule on her lung, about 5 millimeters. Her doctor said they needed to watch it, so they did another CT scan 3 months later. The nodule looked slightly bigger, so they recommended a biopsy. The biopsy showed some abnormal cells, not cancer, but not entirely normal either, so they recommended removing part of her lung just to be safe. Margaret had the surgery. The surgery went fine, but during recovery, she developed a blood clot that traveled to her other lung. She spent 2 weeks in the hospital. She developed pneumonia. By the time she finally went home, she'd lost 15 pounds, could barely walk upstairs, and took another 6 months to get back to anything close to normal. And here's the kicker. The final pathology report on the tissue they removed? It was a benign inflammatory nodule. Not cancer, not precancer, just a small area of inflammation that would never have caused her any problems in her entire life. But the screening found it. One thing led to another, and Margaret nearly died from the treatment of a problem that wasn't actually a problem. This happens every single day in hospitals across the country. We find things that look suspicious. We investigate. We treat. And sometimes the investigation and treatment cause more harm than the thing we found would have ever caused. This is what doctors call overdiagnosis and overtreatment, and it's one of the biggest problems in modern medicine, especially for seniors. So let's dive into the 7 health checkups that may do more harm than good after age 60. Number 1. Annual full physical exams with extensive lab work. Now, I know this sounds crazy. How could going to your doctor for a checkup be harmful? Let me explain. The annual physical exam where a healthy person with no symptoms comes in, gets examined from head to toe, and has a dozen blood tests ordered has become a ritual in American medicine. But here's what the research actually shows. Multiple large studies, including reviews by the Cochrane Collaboration, which is considered the gold standard in medical evidence, have found that annual physicals for healthy adults do not reduce mortality. They don't help you live longer. They don't prevent heart attacks or strokes. They don't catch cancer early in any meaningful way. What they do is lead to a cascade of additional testing. Think about it. When you run 15 different blood tests on a healthy person, statistically, at least 1 or 2 of those results will come back slightly abnormal just by chance. Labs have normal ranges, but those ranges capture about 95% of healthy people, which means 5% of healthy people will have a result outside the normal range for any given test. So your doctor sees a slightly elevated liver enzyme. Now they want to do an ultrasound of your liver. The ultrasound shows a small cyst, which is incredibly common and almost always harmless. But now they want to do a CT scan to characterize it better. The CT scan shows the cyst is probably benign, but there's a tiny chance it could be something concerning, so they recommend a biopsy or monitoring with repeat scans. Every step of this process involves radiation exposure, risk of complications, anxiety, and cost. And in the end, 99 times out of 100, it was nothing. Now, I'm not saying you should never see your doctor. If you have symptoms, if you have chronic conditions like diabetes or heart disease that need monitoring, if you need medication refills and management, of course you should see your doctor regularly. But the evidence is clear that if you're a healthy 65-year-old with no symptoms and no chronic conditions, having an annual physical with extensive lab work is unlikely to benefit you and quite likely to lead to unnecessary follow-up testing. A better approach? See your doctor when you have symptoms or concerns. Have a relationship with a primary care doctor who knows you. But don't feel pressured into annual extensive workups if you're feeling fine. The American Board of Internal Medicine, through their Choosing Wisely campaign, has actually recommended against routine annual checkups for asymptomatic adults because the harms often outweigh the benefits. Number 2. PSA screening for prostate cancer in men over 70. Gentlemen, this is a big one, and it's controversial, so I need you to really hear what I'm saying. The PSA test, which stands for prostate-specific antigen, is a blood test that's supposed to screen for prostate cancer. For decades, doctors recommended that all men over 50 get annual PSA testing. It became standard practice. But then researchers started looking at the actual outcomes, and what they found was troubling. Multiple large randomized controlled trials, including the massive U.S. Preventive Services Task Force analysis, found that PSA screening in men over 70 does not reduce prostate cancer deaths. It doesn't help you live longer. What it does do is lead to a huge number of unnecessary biopsies, surgeries, and radiation treatments. Here's why. Prostate cancer is incredibly common in older men. If you do autopsies on men who died of other causes in their 70s and 80s, you'll find prostate cancer in 40 to 50% of them. But here's the critical point. Most of these prostate cancers are slow-growing. They would never have caused symptoms. These men would have died of something else, heart disease, stroke, or just old age, with prostate cancer present in their body but not being the thing that killed them. But when we screen with PSA, we find these cancers. And once we find them, the tendency is to treat them. Prostate cancer treatment is not benign. Surgery for prostate cancer has significant risks, including permanent erectile dysfunction in 30 to 60% of men, urinary incontinence where you leak urine and need to wear pads in 10 to 20% of men, and serious surgical complications in about 5% of cases including infection, blood clots, and even death. Radiation therapy for prostate cancer also causes erectile dysfunction in about 40 to 50% of men, bowel problems including diarrhea and rectal bleeding, urinary problems, and long-term increased risk of other cancers from the radiation itself. So let me paint the picture clearly. You're 72 years old, feeling great, no symptoms. You get a PSA test. It comes back slightly elevated. Your doctor recommends a prostate biopsy, which by the way is not a pleasant procedure and carries risks of infection, bleeding, and pain. The biopsy finds cancer. It's a slow-growing type, which most prostate cancers are. But you've been told you have cancer, so you agree to treatment. You have surgery. Now you're dealing with erectile dysfunction and wearing pads because you leak urine when you cough or laugh. Meanwhile, studies show that if you had never gotten that PSA test, if you had never known about that slow-growing cancer, you would have lived just as long and had a much better quality of life for those years. The U.S. Preventive Services Task Force now recommends against routine PSA screening in men over 70, and recommends that men between 55 and 69 make an individual decision with their doctor after discussing the benefits and harms. Many major medical organizations have backed away from recommending routine PSA screening specifically because the harms outweigh the benefits for most men, especially as you get older. Now, there are exceptions. If you have symptoms like difficulty urinating, blood in your urine, or bone pain, you should absolutely be evaluated. If you have a strong family history of aggressive prostate cancer, the calculation might be different. But for the average man over 70 with no symptoms, PSA screening is more likely to harm you than help you. Number 3. Mammograms in women over 75. Ladies, I know this is going to be difficult to hear because we've been told for decades that mammograms save lives. And for women in their 50s and 60s, there is evidence that screening mammography does reduce breast cancer deaths, though the benefit is smaller than most people think. But after age 75, the evidence changes dramatically. Several large studies have shown that mammogram screening in women over 75 does not reduce breast cancer mortality. Part of the reason is that as you get older, you're more likely to die of other causes like heart disease before a slow-growing breast cancer would have become life-threatening. And like prostate cancer, many breast cancers, especially in older women, are slow-growing and would never cause symptoms or death. But here's what mammogram screening does cause. False positives are incredibly common. Studies show that if you get annual mammograms for 10 years, you have about a 50 to 50 chance of having at least one false positive result. A false positive means the mammogram looks suspicious, but when they do further testing with additional imaging or a biopsy, it turns out not to be cancer. Each false positive leads to weeks or months of anxiety, additional radiation exposure from follow-up mammograms, and often painful biopsies. And about 20% of breast cancers found on screening mammograms are what we call overdiagnosed. This means they're real cancers, but they're so slow-growing that they would never have caused symptoms or death. But once they're found, they're treated with surgery, radiation, and sometimes chemotherapy. Breast cancer surgery can cause lymphedema, which is chronic painful swelling of the arm. It can cause chronic pain. Radiation therapy causes skin damage, fatigue, and increases the risk of heart disease and other cancers. Chemotherapy in older adults is particularly harsh, causing severe fatigue, immune suppression, cognitive problems, and significantly reduced quality of life. So you have a 77-year-old woman who gets a mammogram, it finds a small cancer, she goes through surgery and radiation, and now she has chronic arm swelling and fatigue. Meanwhile, that cancer was so slow growing that she would have lived another 10 years without ever knowing it was there if she hadn't been screened. The American Cancer Society now recommends that women over 75 who have a life expectancy of less than 10 years should not continue screening mammograms. The U.S. Preventive Services Task Force says there's insufficient evidence to recommend for or against mammograms in women over 75, which is medical speak for "we don't think there's a clear benefit." This doesn't mean if you feel a lump in your breast you shouldn't get it checked out. Absolutely you should. But routine screening mammograms in healthy women over 75 with no symptoms are unlikely to extend your life and quite likely to lead to unnecessary anxiety and treatment. Number 4. Colonoscopies in adults over 75. Colonoscopy screening for colon cancer is another sacred cow in American medicine. And again, for people in their 50s and 60s, there is solid evidence that colonoscopy screening reduces colon cancer deaths. But after age 75, particularly after age 80, the picture changes significantly. The U.S. Preventive Services Task Force recommends against routine colonoscopy screening in adults over 85, and recommends individual decision-making for adults 76 to 85. The reason is similar to the other screenings we've discussed. Colon cancer typically grows slowly. If you've been getting regular colonoscopies and they've been normal, your risk of developing colon cancer that will kill you in the next 10 years is very low. Meanwhile, colonoscopy is not without risks, especially as you get older. The procedure requires sedation, which carries cardiovascular risks in older adults. There's a risk of perforation, which is tearing the colon, which happens in about 1 in 1,000 procedures. Perforation is a medical emergency requiring surgery and can be fatal, especially in older adults. There's also a risk of bleeding, especially if polyps are removed. The bowel preparation before a colonoscopy, where you have to drink large amounts of laxative solution and essentially empty your entire colon, can cause severe dehydration and electrolyte imbalances in older adults. I've seen seniors end up in the hospital with kidney failure or heart rhythm problems from the prep alone. And like other screenings, colonoscopies can find things that lead to more procedures. They might find a polyp and remove it, which causes bleeding that requires hospitalization. Or they might find something concerning that leads to CT scans, more invasive procedures, and anxiety. If you're 78 years old and your last colonoscopy at age 68 was normal, there's a very good chance that getting another colonoscopy is going to cause more problems than it solves. Many gastroenterologists are now suggesting that if you've had consistently normal colonoscopies and you're over 75, especially if you have other health conditions, you might be better off stopping screening. Again, this doesn't mean if you have symptoms like rectal bleeding, unexplained weight loss, or changes in your bowel habits that you shouldn't be evaluated. Those are warning signs that need investigation. But routine screening colonoscopy in healthy seniors over 75 is increasingly recognized as causing more harm than benefit. Number 5. Bone density scans and aggressive osteoporosis treatment in very elderly women. Osteoporosis screening with bone density scans, called DEXA scans, is recommended for women over 65. And treating osteoporosis to prevent fractures makes sense for many women in their 60s and 70s. But as women get into their 80s and beyond, the situation becomes more complicated. The medications used to treat osteoporosis, particularly bisphosphonates like Fosamax and Boniva, do reduce the risk of fractures. But they also have significant side effects, especially with long-term use. They can cause severe bone, joint, and muscle pain. They can cause acid reflux and esophageal irritation. More concerning, long-term use is associated with atypical femur fractures, which are unusual breaks in the thigh bone that can be devastating. They're also associated with osteonecrosis of the jaw, which is when the jawbone starts to die, often triggered by dental work. For a woman in her 80s or 90s, especially if she has other serious health conditions, the question becomes whether preventing a possible hip fracture 5 or 10 years down the road is worth taking medications that cause daily pain, digestive problems, and carry the risk of rare but serious complications. Moreover, studies have shown that many of the interventions we recommend to prevent fractures in the elderly, like these medications, have a number needed to treat of 50 to 100. This means you need to treat 50 to 100 women with the medication for 5 years to prevent one fracture. So 49 to 99 women are taking the medication, experiencing side effects, and getting no benefit, while one woman has a fracture prevented. There's also the issue of fall prevention versus bone strengthening. The truth is, most hip fractures in the very elderly happen because of falls, not just because of weak bones. Money and effort spent on fall prevention measures like physical therapy for balance and strength, removing tripping hazards at home, and treating vision problems might be more effective than medications to slightly increase bone density. I'm not saying older women shouldn't treat osteoporosis, but there should be an honest conversation about the real benefits versus the real risks, especially in women over 80. In some cases, the most appropriate approach might be to stop screening, stop medications, and focus on fall prevention instead. Number 6. Aggressive diabetes screening and tight blood sugar control in seniors with limited life expectancy. Diabetes is a huge problem, and managing blood sugar is important to prevent complications like heart disease, kidney failure, and nerve damage. But here's what many doctors and patients don't realize. Those complications take years, often 10 to 20 years, to develop. For a person in their 80s with multiple health problems, aggressively managing their blood sugar to prevent complications they might never live long enough to develop can actually be harmful. Tight blood sugar control requires multiple medications, frequent monitoring, strict dietary restrictions, and carries significant risks. The biggest risk is hypoglycemia, which is when blood sugar drops too low. In older adults, hypoglycemia can cause confusion, falls, loss of consciousness, seizures, and even death. It can also cause or worsen dementia. Studies have shown that in frail elderly patients with multiple chronic conditions, aggressive diabetes treatment with tight blood sugar targets actually increases mortality. They die sooner, not later. The reason is likely related to hypoglycemia and the stress that intensive treatment puts on the body. For an 85-year-old with heart failure and dementia, having a hemoglobin A1C, which is a measure of average blood sugar, of 8 or even 9 might be perfectly acceptable. Trying to get that number down to 6.5 or 7 with multiple medications is likely to cause more harm than good. The American Diabetes Association now has more relaxed blood sugar targets for older adults with limited life expectancy and multiple health conditions. But many doctors still screen aggressively for diabetes in the very elderly and treat aggressively when it's found, even when a more relaxed approach would be safer and allow for a better quality of life. Nobody wants to eat candy bars all day, but an 85-year-old should be able to enjoy a piece of birthday cake without their doctor scolding them about their blood sugar. Number 7. Cardiac stress tests and cardiac catheterizations in asymptomatic seniors. This is a big one that causes a lot of unnecessary procedures and harm. Many seniors undergo cardiac stress tests as screening tests even though they have no chest pain, no shortness of breath, and no symptoms of heart disease. The logic is that we want to catch heart disease early. But here's the problem. Cardiac stress tests have a high rate of false positives, especially in older adults and especially in women. A false positive means the test looks abnormal, suggesting there might be blockage in the coronary arteries, but when you do more invasive testing, the arteries are actually fine. When a stress test is abnormal, the next step is usually a cardiac catheterization, where they thread a catheter through your blood vessels to look at your heart arteries directly. Cardiac catheterization is an invasive procedure with real risks including bleeding, blood clots, heart attack, stroke, kidney damage from the dye they inject, and even death. The risk of a major complication is about 1 to 2%. And here's the thing. If the stress test was a false positive, you just underwent an invasive procedure with significant risk for no reason. Even if the catheterization finds some blockage, studies have shown that in people without symptoms, stenting those blockages does not reduce the risk of heart attack or death compared to just taking medications like aspirin, statins, and blood pressure medications. A landmark study called the COURAGE trial showed that in patients with stable coronary artery disease, meaning they had blockages but weren't having active chest pain or heart attacks, stenting did not improve outcomes compared to medical therapy alone. Stenting is life-saving if you're having a heart attack. But in stable, asymptomatic patients, it doesn't provide benefit and exposes you to all the risks of an invasive procedure. So the cascade goes like this. Asymptomatic 72-year-old gets a screening stress test. Test is abnormal. Cardiac catheterization is done. Some blockages are found. Stents are placed. Patient develops a complication from the stenting, maybe a bleed requiring transfusion or kidney damage from the dye. And in the end, research shows their risk of future heart attack wasn't actually reduced. Major cardiology organizations now recommend against routine cardiac screening in asymptomatic individuals because the harms outweigh the benefits. If you have chest pain, shortness of breath with exertion, or other symptoms, absolutely you should be evaluated. But if you're feeling fine, screening stress tests in seniors often cause more problems than they solve. So those are the 7 health checkups that may do more harm than good after age 60. Let me be very clear about what I'm saying and what I'm not saying. I'm not saying you should avoid all healthcare. I'm not saying you shouldn't see doctors or take medications. What I am saying is that more testing is not always better. More screening is not always better. And at a certain age, with certain health conditions, the risks of screening and aggressive treatment start to outweigh the benefits. The key is individualized care. Every person is different. A healthy, active 75-year-old with no major health problems is very different from a frail 75-year-old with heart failure, dementia, and multiple other conditions. The screening and treatment approach should be different for these two people, but often it's not. So how do you navigate this? How do you know which screenings and tests are right for you? Here are some questions you should ask your doctor before agreeing to any screening test or procedure. First, what is the purpose of this test? Am I having symptoms that need to be investigated, or is this a screening test for someone with no symptoms? Second, if the test finds something abnormal, what would we do about it? Would we treat it aggressively, or would we just watch it? Third, what are the realistic chances that this test will find something that will actually benefit me? And when I say benefit, I mean help me live longer or have a better quality of life, not just find an abnormality. Fourth, what are the potential harms of this test? Not just the test itself, but the cascade of additional testing and treatment that might follow if the test is abnormal. Fifth, given my age, my overall health, and my other medical conditions, is this screening test likely to help me or harm me? And finally, what would happen if I chose not to have this test? Would I be putting myself at significant risk, or would I likely be fine? These are fair questions, and a good doctor will respect them and give you honest answers. If your doctor seems offended or dismissive when you ask these questions, that's a red flag. You deserve to be an informed participant in your healthcare decisions. Let me tell you about another patient I'll call Robert. He was 81 years old, had diabetes and mild heart failure, but was managing well and enjoying life. His doctor wanted to do a screening colonoscopy because it had been 10 years since his last one. Robert came to me for a second opinion. We had a long conversation. I explained that at his age, with his health conditions, a colonoscopy had risks. The bowel prep could worsen his heart failure. The sedation carried risks. And even if we found polyps, his life expectancy was probably about 5 to 7 years based on his heart condition, so a slow-growing colon cancer wasn't likely to be what killed him. Robert decided not to have the colonoscopy. He focused instead on enjoying time with his grandchildren, traveling with his wife, and managing his diabetes and heart failure. He lived another 6 years and died peacefully at home with his family. He never developed any colon cancer symptoms. The colonoscopy he skipped didn't cost him anything in terms of length or quality of life, and it saved him from the risks and discomfort of an unnecessary procedure. That's the kind of thinking I want you to apply to your healthcare after 60. Ask yourself, is this test or procedure going to help me live better or longer, or is it just medical busywork that might cause more problems than it solves? There's also a financial aspect to this that we can't ignore. Medicare and insurance companies often pay for these screenings, so it might feel like they're free. But they're not free to the healthcare system, and ultimately we all pay through higher insurance premiums and taxes. More importantly, the downstream costs of unnecessary follow-up tests, procedures, and complications are enormous. But more than the financial cost is the human cost. The anxiety of waiting for test results, the discomfort and risk of biopsies and procedures, the side effects of treatments for conditions that might never have bothered you, the time spent in doctors' offices and hospitals instead of with family and friends. These costs are real, and they fall on you. I want to end with this thought. As you get older, the goal of healthcare should shift from trying to prevent every possible future problem to maintaining quality of life and function. It should be about helping you do the things you love for as long as possible. It should be about managing symptoms that bother you. It should not be about finding problems you don't have symptoms from and then treating those problems in ways that make you feel worse. You have the right to say no to tests and procedures that don't align with your values and goals. You have the right to prioritize quality of life over quantity of life. You have the right to accept some level of risk in order to avoid burdensome medical interventions. I hope this video has given you a different perspective on healthcare after 60. I hope it's empowered you to ask questions and make informed decisions. And I hope it's reminded you that you are in control of your healthcare decisions. Doctors can advise, but you decide. If you found this information valuable, please share it with other seniors in your life. These are conversations we need to be having openly. And if you have experiences with unnecessary testing or procedures, or if you've successfully advocated for less aggressive care, I'd love to hear about it in the comments. Thank you for watching The Gray Hub, where we bring you honest, evidence-based health information for your best years. Take care of yourself, ask questions, and remember that sometimes the best healthcare decision is to do less, not more. Most importantly, please subscribe.